Welcome back to another episode of The Big Bid Theory. This is Bill Culhane from our studios about a long Tiger Woods tee shot from downtown Austin. As always, Rick Jennings is alongside and Kevin Henderson is our digital marketing guru. Rick, what have you been up to? How was your weekend?
I had a good weekend, Bill. I took in the great American pastime of dog sitting for a friend.
Oh, nice.
So everyone likes dogs, so nice relaxing weekend, played some tug of war, and it's good to be back here, and I gotta say it's a little odd to be on the other side of the glass for once, so thanks for having me in here.
Yeah, sure. The first episode of the show, the first episode of Season 5, we had Brian Palish on to talk about infrastructure. What did you think about that conversation?
That was a really neat conversation, a lot of really good ideas, and a lot of really good ways to sort of implement that into just your regular bidding process and seeing what the government is purchasing. And so I think people in that sector have a lot to learn from it. And just the same as we go forward with this new season, I know we're going to have a lot that we do learn coming up from here as well.
No doubt about that. And on that note, coming up in this episode, going to visit with an expert on homelessness here in the United States, and clearly an important topic affecting many people and numerous communities across the United States, people who are homeless. I came across during my research, I watched a number of videos, a number of presentations. The team here, we looked at a bunch of resources regarding homelessness. Rex Holbein is the executive director of the nonprofit Facing Homelessness as one example. And he said in a TED Talk he gave a few years ago, homelessness is real people with real suffering. It isn't a label. It isn't an issue facing those people over in that part of town or somebody in that family 4 streets over. In some places, to varying degrees, the public sector, and I'm talking about, of course, federal, state, and local agencies, are taking action. You see various estimates out there. In the United States, somewhere around 500,000 plus people are considered homeless. One of our researchers, Marish, came across an interesting article in Fast Company. It tells the story how some are using technology, using real-time data on the homeless to help decision makers determine who needs what services. Fast Company, and go find it, Fast Company, March 11th article, the title, 3 cities in the U.S. have ended chronic homelessness. Here's how they did it. Check it out. So as we continued our research into the topic of homelessness, homeless services, and solutions, Marish came across the name Dr. Margot Kushel. Her name kept popping up. And from her UCSF bio, Dr. Kushel is a professor of medicine in the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital and Trauma Center and the director of the UCSF Center for Vulnerable Populations. We'll hear from her, but her research focuses on reducing the burden of homelessness on health through examining efforts to prevent and end homelessness and mitigating the effects of housing instability on healthcare outcomes. So we invited Dr. Kushel onto the show. Here's my visit with her.
Now we bring in Dr. Kushel on the Big Bid Theory hotline. First of all, Dr. Kushel, thank you for joining us. I mentioned the UCSF Center for Vulnerable Populations. Please share a little bit of background on how you got involved in addressing homelessness and kind of paint a picture on what the center there at UCSF, what you folks are doing.
So the UCSF Center for Vulnerable Populations is a research center where we're based at the medical school, but really our role is to try to find answers to questions of how we build what we say is health equity, or how we give everybody the best chance at a healthy life. And we do that in many different ways, but really we don't try to create research that sits on the shelf. We want it to be research that people engage with, that the public engages with, that policymakers engage with, to try to help get us towards health. And we focus on many different things. Homelessness is one of the things that we focus on. And the reason why a doctor, a physician, is focusing on homelessness is that we realize that only a very small percentage of what makes people healthy is the medical care that they receive. And a much bigger influence is all of the other influences on people's lives, what we call the social determinants of health, or things like where you live, your access to education, to food, to all of those other things that make a community. And so in my work at the center, I particularly focus on the role that housing plays in determining someone's health. And what I can tell you is that one of the most important things that we can do to create healthy environments or to make people healthy is to ensure that they have stable and adequate housing.
Now, how did you get involved? If you can kind of take us back. For example, my son, when he was in 7th grade, knew he wanted to be a teacher, knew he wanted to focus on special education. I understand some people that maybe doesn't happen until the final semester of their senior year, their undergrad, and some people, you're 50 years old and the light bulb goes on. But what about you?
Yeah, for me, I went to medical school and training, and I was very interested in creating health equity. But to be honest, what I thought I would focus on was the health of the working poor. But when I got to my medical training in residency, which is what we physicians do after med school, where we really become doctors, I was training in San Francisco, spending most of my time at what we then called San Francisco General Hospital. Now we call it Zuckerberg San Francisco General. But which is a public hospital for the city and county of San Francisco. So it is the hospital that people use who don't have private insurance, whether they have public insurance like Medicaid or Medicare or no insurance at all. And when I was a resident there in the mid-1990s, on the inpatient service, on the hospital service, 1/2 of all of the patients we cared for were homeless. And it was really quite terrible. We would admit people to the hospital. They would be very sick. We would give them all of the best medical care we could come up with. And then we would be told that we had to discharge them or send them out of the hospital because the hospital really isn't the place for someone to live. And I was faced with patients begging me not to send them back out to the street where they were frightened, where they were cold, where they were wet, and where they knew they couldn't get healthy. Eventually, we would have to discharge people, and inevitably 2 or 3 days later, they would be back sicker than they were when I let them go. And I remember thinking, this really doesn't make sense. This is not the best way to make people healthy, and it's really not what I became a physician to do. And at that point in time, I kind of had this light bulb go off that what I really wanted to spend my career doing is looking at the connections between homelessness and health, and more importantly, figuring out where do we go from here? How do we make this better?
You're a doctor. You're an MD, and to kind of take you behind the curtain, my wife is a critical care nurse at a hospital here in Austin, and I told Tracy about our upcoming conversation, and she and I discussed the topic, and you paint the picture very well. The impact on the patient is clear, but what about the impact on the healthcare facility, the healthcare provider themselves? And as you mentioned, when these patients present every week, every month, it's the same faces coming through the door.
Yeah, I mean, it's heartbreaking and it's discouraging because we know that we can be our best selves. We can be the best physician you can possibly be, the best nurse you can possibly be, and yet you realize that what you're doing is not really helping. And that is really frustrating. I think we're also all aware in healthcare that healthcare spends a lot of money, that we value healthcare, we spend a lot of money in healthcare, and we really don't want to be wasteful. And it certainly feels wasteful to sort of patch people up and then send them back to the same situation that got them sick in the first place. And then just on an individual level, I think it leads to a lot of burnout and discouragement because no one becomes a physician or a nurse to be the person who has to throw somebody out back onto the street and have to see them suffer like they do. I think as healthcare providers, we really have front row seats to really what a crisis this is and the enormous, incalculable human toll of homelessness.
Great points indeed. As the listeners to this show, I travel across the country in my lives, coast to coast. Not long ago, among the cities I visited, San Diego, Portland, Memphis, New Orleans, Atlanta, here in Austin. And I know that Dr. Kushel, it takes no effort at all to see there are homeless in the U.S. It's not isolated to a region. It's certainly not isolated to a city. I have a friend of mine, Stephen, who spent a week and a half in Japan and just got back yesterday, as a matter of fact. Stephen said in the week and a half that he traveled across Japan, he saw 3 homeless people, not 3 people in Tokyo. He saw 3 people total. And so I guess my question to you is, because you're clearly boots on the ground, when people say, I'm not homeless, doesn't matter to me, I don't know anybody directly in my family, in my friend group who's homeless, it's only men between the ages of 30 and 65. I don't care. I don't care about this. How big of a problem is it in the U.S.?
I mean, this is an enormous problem, and it is not an equal opportunity problem. We know that in the United States, 500,000 people are homeless every single night. We know that 1 in 4 people who experience homelessness are children living with their parents while they're homeless. And we know that Black Americans are at 3 to 4 times increased risk of homelessness. I don't think this is a problem that you can close our eyes to. And as you mentioned, when you leave this country and you see how different it is in many of the other comparable countries, it really speaks to, I think, a major policy failure that we've had in the U.S. I think it speaks to the really effects of racism that we live with every day in the United States, and I think it speaks to a problem that begs addressing. I am proud to be an American, but I think we're a lot better than this, and we have to do better than this.
As I looked in the BidPrime database, monitoring government bids and RFPs from across the country, federal, state, local, and there's some action being done by government agencies. A significant majority of those requests are coming from state and local. And I went back and looked. I started January 1st of 2015, and there's about 1 new request per day across the United States of America. So some action is being taken. But Dr. Kushel, if somebody gave you the magic wand and said, you're in charge of what government agencies are doing, what would you like to see more of?
I mean, the first thing we need to see more of is really a vast new effort on deeply affordable housing. We across the country are experiencing an affordable housing crisis. Right now, across the country, there are only 35 units of housing that is affordable, meaning that families can spend less than 30% of their household income on rent. For every 100 families who are extremely low income, or families that make 30% or less of the area median income where they are. This problem, the homelessness crisis that we see, is not a result of mental health disabilities. It's not a result of substance use disabilities. At its heart, it is a crisis of a lack of affordable housing. We weren't always this bad, but we've been this bad since the early 1980s, since the federal government really backed out and really significantly decreased their efforts on affordable housing. If we were able to build and create housing that was affordable to people who make between 0 and 30% of the area median income, a lot of this problem would disappear overnight. So that has to be role number 1, is really focusing on the housing affordability crisis. You can do that primarily by building housing that is subsidized, that's available. You can also do that by lifting people's incomes to a certain extent. If people had more income, they could spend more on housing. But what we really need to do is a massive investment in deeply affordable housing, or the type of housing that families who are on the lower third of the income scale can afford and still feed their family and still clothe their family and still get health care for their family. The other thing that we're doing quite a good job on, but we need more, is the recognition that some people will always need more support. And that's true in any culture that you go. And that those folks who need more support, we actually know what works for them. For folks who have significant, what we call behavioral disabilities, mental health problems or substance use problems are the main ones, we know that we can effectively house them through something called Housing First, or permanent supportive housing. What this is housing that's subsidized so that they pay only 30% of their income on rent, which is the sort of acceptable amount that you're supposed to spend on housing, and that there are services that are available to them. Services like case management and money management, healthcare, mental health care, substance use, and that these services are voluntary. In the old days, we used to demand that the only people who were homeless who could get housed were people who adhered to every rule that was put down, that you don't use substances or that you take your psychiatric medicines. But the problem is, it's almost impossible to engage in those types of treatments while you're still homeless. What Housing First says, which by the way is the law of the land, it's the accepted method of treating chronic homelessness, what it says is bring people into housing first, don't make all these demands on them. But once they're housed, offer them these services. And lo and behold, what we've learned is that 85% of people who enter supportive housing, even if they have very, very, very severe difficulties with mental health or substance use, are able to stay housed. And usually what happens is their mental health and their substance use gets a lot better. So that's another thing that we need to expand as much as we can. In many places, the rate limiting step of expanding that is really the lack of housing, but there are still some places that haven't adopted it as vociferously as others have. And we definitely need more permanent supportive housing. So the first thing I would do is build a lot more deeply affordable housing that is affordable to people who make 30% or less of the area median income. I promise you, if we did that, most of this problem would disappear overnight. And then the next thing we need to do is for the people who need more help is to provide that help in the form of Housing First permanent supportive housing.
Dr. Kushel, I don't know if you heard in the background, but I know that you and I just heard a couple of screams where people are saying, wait a minute, Bill, wait a minute, Dr. Kushel, you're talking about raising my taxes. You're talking about taking my money. Now, in the lead into our interview, I went back, I've spoken with a number of people, and I've done some research, as have Rick and Kevin. And there are a number of people who argue that it's cheaper to house a homeless person than to pay for the health care, the criminal justice system, and the enormous amounts of money spent by nonprofits. Does that make sense?
Yeah, I mean, there are like small disputes about the number, but there's no question that when you add all of the costs together, not just the healthcare costs, because it turns out a lot of these folks don't get enough healthcare, so sometimes the healthcare costs don't even out. But when you add in the amount of money that we spend on sweeps or sort of cleaning up after people who are homeless, the amount of money we spend on emergency shelters, which solve sleep, but they don't solve homelessness, the amount of money that we spend on increased police activity, on the effects on the business environment, and you can easily even out all of those costs by providing housing. The other thing is, let's talk about the moral cost. What does it mean? How do we explain to our children that in a society as wealthy as ours, we have all of these folks sleeping outside? So even without the moral cost, there is a lot of evidence that the amount of money that we spend on shelters, on jail stays that could be avoided, on police activity, on cleaning up public works, as well as on healthcare, you can really offset the cost of the housing. So it's not only the right thing to do, it's likely the economically sound thing to do as well.
And I agree. Well, Dr. Kushel, thank you so much again for spending some time with us on the Big Bid Theory. Are there any references, publications, website research you would like to point our audience in a certain direction?
There's a lot of really good work that's being done on this. Certainly on my website, there's a lot of my own work, but there's really fabulous work on the National Alliance to End Homelessness publishes a lot of really great research that's done there. The National Low Income Housing Coalition has a lot of fantastic statistics about the shortage of affordable housing. That's another really great resource for people to know about.
Very good. Well, Dr. Kushel, and our listeners, our longtime listeners, understand that Kevin will put links not just to your research, but the references that you just provided as well. We appreciate you coming by, and Dr. Kushel, thank you for the great work that you're doing, and hopefully our paths will cross again at some point down the road.
Thanks so much for having me. Have a great day.
As I just mentioned, and Kevin's in the process of doing it right now, we'll add links to those references, including Dr. Kushel's work, in the description of the podcast, as I just said a couple of minutes ago. Moving on to crazy bids, Nina French from the Current Consulting Group has been on the show a couple of times over the years discussing the impact of the ongoing opioid crisis in the U.S. According to data from the CDC themselves, in 2006, there were close to 216 million prescriptions for opioids in the U.S. Improvement in 2017, the CDC reported the total number of prescriptions at slightly over 191 million. Interesting here, of the 3,142 counties in the U.S., only 2,955 had available data to provide to the CDC. It's a little interesting why, 200 or so counties don't have data to provide. But anyway, on to the crazy bit. Think of the training that physicians and healthcare providers go through. Well, the state of Maryland has put out a bid, and I'm going to read right from the bid itself. It is to develop an online CME training program for prescribers of opioids. The details: requesting proposals from vendors to develop an online continuing medical education training program. The CME must address the appropriate use of opioids in the treatment of patients, recognizing opioid use disorder, strategies to prevent patient misuse of opioids, and communication with patients on opioids and risk. In addition, the CME must include Maryland-specific content. So there you go. Even though healthcare providers presumably go through a lot of training and know a lot of what's covered in this bid, the state of Maryland is taking that extra step to ensure that healthcare providers in the land of pleasant living are complying with all the rules, all the laws, all the regulations having to do with the prescription of opioids. That's going to do it for this episode. Many thank yous for helping us to spread the message. Thanks for sharing, downloading, and following the Big Bit Theory. Our visit with Brian Palish on last episode created an email buzz. We'd like to hear what you have to say about homelessness or whatever comes to mind. You can email me at bculhane@bidprime.com. Yes, we're on Twitter. You can follow us at The Big Bit Theory. My Twitter is contract_hunter, and TBBT is also on Facebook. Keep that in mind as well. And also over on LinkedIn as well. Powered by BidPrime, for our entire TBBT team, striving to bring topics to you that we all care about. Thank you to Dr. Margot Kushel. Should homelessness in the U.S. be important to you before you're directly impacted by it, or is it for those other people to worry about? Thank you to our audio guru, Rick Jennings, for pushing the buttons and turning the dials. This is Bill Culhane. Until next time, go Gunners, Barracudas, Tigers, Bobcats, and Cubs, and we wish you all the best in growing your business.
Powered by BidPrime, we thank you for tuning in to The Big Bid Theory. From Austin, Texas, the show is produced by Bill Culhane and Jim Ward. Producer and engineer is Rick Jennings. Distribution, research, and production assistance by Lauren Jones and Kevin Henderson. You can find other episodes of The Big Bid Theory on platforms to include iHeart, iTunes, Spreaker, and Google Play.